Get this party started. All right, good morning, everybody. So inpatient team meeting for December 19th, 2025. I don't have any special guests. I do have Trisha on the call, so there's very good chance that we're going to run into some items that she may be able to speak on concerning like CHG and stuff like that. I've got an agenda put together. We can get some comments from her on that. I don't have Omar from pharmacy here at this meeting, although he does have a tendency to drop in a little bit later sometimes. But if there are any questions that you guys have for outside departments that you would like me to posit over to them, please just post something in the chat, or feel free to shoot me a message on my phone, email, etc. That would all be fine. So moving in, just going to cruise through. Some of these are topics that I spoke on with the team leads yesterday. And some of them are topics that the team leads brought forward to cover with everybody in today's meeting. And then some of them are some updates that are kind of coming down the line. So just some quick reminders. We've recently had some increased incidents of near falls or actual falls occurring with patients. Most of these instances have been involving patients that are confused, typically requiring additional monitoring, either outside or inside the room. And unfortunately, a lot of these cases have been stretched down, different hallways, and we're not exactly in a position to be able to shuffle people around because of the swing beds tying up specific rooms. So it does make it very challenging in order to be able to spread the resources to where they need to be. The big thing here is just making sure that when we are implementing our kind of fall bundle for these patients, that the bed alarm is one of the aspects that we're consistently ensuring we're utilizing for those patients. So in at least two of the near fall or fall instances that we've had in the last month, we have had bed alarms not being activated. Please, if it's an issue with the bed not activating the alarm or something of that nature, we just have to make sure that we get those work orders in for those. But otherwise, it is a low-hanging fruit task that's easy to forget. You pop into a room, help somebody stand up, take them to the bathroom, set them back down in bed. You're on the hustle because you got to move to the next room, and you step out of the room without putting the bed alarm back on. It's easy to forget, but it is one of those practices that figuring out a way to ensure that when you are in that room, a mental checklist that you run through. We typically are doing that pain potty positioning kind of concept, asking the patient if there's anything else that they need before they go. Stick that bed alarm check mark into that pain potty positioning that you're running through in your head when you're in that room with that patient. Make that one of those checklist items that you're consistently checking every time that you step into a room. Particularly if the patient needs it. Some things that are going to be coming, we finally did track down some yellow gowns with plastic snaps. So those are going to be on order. So just to kind of help easily highlight those high fall risk patients, literally highlight, in addition to the yellow socks that we already have available. There's been some talk about having yellow stars to be able to put outside of the rooms as well, just trying to broaden the amount of identifiers that we have for these potential fall patients. In combination with falls, was brought up also that we've had some instances where patients have been choking or near choking. Key thing here is just being sure that we slow down and take a beat when we have someone that has had a status change or is new, that we haven't encountered yet. And just stick around for that, first bite of food or first drink of water. It's very common for us to be wanting to move quickly, get trays passed quickly, be able to execute on that function very rapidly because there's a lot of trays that need to be passed. We're trying to move quick, and I appreciate the efficiency, but you know, taking an extra beat on somebody that you take a look at and you just kind of think to yourself, you know, this person might have a hard time swallowing. I'm not really sure. And just having them take a drink of water, even just taking a sip of water can typically be enough to be a telltale indicator of that person being a high risk for aspiration versus not. If they're easily able to cruise through that glass of water, that's a pretty good indicator that you know, they probably can advance to at least something soft. If you're highly suspect, the next step is to give them something soft to try and swallow. And if they can get past that, then they're probably good to go with what they have on their tray. The key thing is on these is, you know, your post-op patients. So, you know, somebody is able to eat, you know, myself or anybody on this call, you're able to eat and drink just fine before you go back to surgery. You go back to surgery, you get some anesthetic put in place, general anesthetic, and it, you know, it messes with your head, it messes with your muscles, it messes with your coordination, and you know, even a person like any of us on this call right now could go from being a perfectly capable of swallowing to choking on a small amount of jello, just as a consequence of the anesthetic that's been applied. So big one to watch out for is those post-op patients. Anytime you've got somebody coming back from surgery, you always want to start out with liquids first, then advance them to something soft like mashed potatoes, jello, something of that nature, pudding, oatmeal, something that's easily able to slide down. And then you can toss a sandwich or something like that their direction. It's just very common occurrence for people to have that post-op aspiration risk due to the anesthetic, especially if they have an ET tube placed as part of their case. Most often, we don't have to do ET tubes on our cases, which is nice. But even when they do I think they use like the combi tube. So even when we're using those, there's still going to be some a little bit of stretching and damage to the throat when they put one of those in. So these patients still carry a little bit of a risk. So just something to keep in mind before you drop a tray and deuce out. You know, if it's somebody that's post-op or somebody that, you know, you're kind of sketchy on, you haven't seen them eat yet, you haven't seen them drink really, just have them drink some water first and see how they do, see how they progress. And of course, if they have a problem, you know, then that's when we grab the nurse, we get them in there to do a full aspiration assessment and check that patient out to see kind of where they're at. Do we need to thicken things of that nature? Lines and infection prevention. So this is where Trish is going to come in. There's been a lot of discussion and talk about CHG baths for the classifications of patients that our policy is in place for doing CHG baths. And that covers all of our ICU patients, any patient that has a central or a PICC line, or any patient that's post-op for 5 days after their post-op. And kind of the key concern has consistently been, hey, we have these CHG wipes. When we put these on and wipe down the patients, we leave them on the skin, and there's a concern that it's going to cause, you know, drying of the skin and then breakdown of the skin, especially if we're doing this day in and day out for a central or a PICC line patient. So this is where the transition is that we can use for those patients that we're doing a repeat, on their CHG baths on a nightly basis. So we do have CHG soap that comes in a separate container, so it's not baked into the wipes. That can be used if the patient's able to shower, get up and use the shower. We can have them use that CHG soap, and it's got a dwell time of about 5 minutes, so about the amount of time that you should leave shampoo in your hair. And the patients can bathe with that CHG soap instead of doing the wipe down with the towels that are in the packet. The other alternative is that CHG soap can also be used for bedside bed baths as well. You can also use the CHG wipes and then have a bed bath container that's just got water in it. So once you apply the CHG, you give it that 5-minute dwell time, and then you wipe it down in order to be able to clean that material off. So the dwell time is giving the CHG an opportunity to kill that bacteria that's on the person's skin. And the key here with using the CHG baths, period, is, anytime that we have any kind of an opening in the skin, post-op, central line, PICC line. And then for our patients that are in the ICU, they're just typically higher risk classification patients. We don't want them catching something else while they're, already in the ICU being treated for something. That CHG is going to cut down on the amount of colonization of bacteria on the skin for that patient. Beyond what we can do with just soap and water. So it's just an extra measure to help reduce the risk of a central line and, a catheter infection, right? Not a Foley catheter, but a central line or a PICC line infection. And then also for our surgical site infections, it just helps to reduce the risk. Tricia, anything that you want to add on that component? Team, any questions that you may have? And please.
Yeah, Keenan, you covered it really well. Is just super important. We don't want to be responsible for giving a patient bacteremia, and we have been very successful since we implemented this protocol.
The last little component, and we did actually get clarification on a patient's documentation from earlier in the week concerning central line dressing change. It was performed, the documentation was caught up, but this is just kind of a general reminder as far as just ensuring that we're consistently hitting those central and PICC line dressings on Tuesday evenings. There are going to be times, and this will happen, where it's just not feasible to be able to get that dressing change done, whether it's because the patient is in a very uncomfortable, painful situation, and doing the dressing change would only push them further over the edge. Maybe the patient is away for some reason. Maybe the situation on the floor, we have patients that are coding, there's multiple rapid responses. There's too much happening in order to be able to make that happen. That's going to happen. There are going to be times where we're just not able to squeeze something in. The kicker is if that is the case, it is critical that we just are able to pass that forward in communication, so that way the next team is able to pick up and carry it forward. Now, that should be rare, right? That should be rare. It shouldn't be consistently, every single week. Tuesday nights are the busiest night of the week, and we just weren't able to get to it, now the last 9 weeks in a row, right? For all of the patients that have PICCs and central lines, we do want to be putting our best foot forward consistently, but there are going to be those times where one patient falls out. It gets communicated over to the day shift staff, that Wednesday morning, and day shift staff is able to pick up and be able to make the dressing change for that patient. So, any other questions for anybody on CHG stuff? I know there's been a lot of questions that folks have had. Go for it, Becca.
Good morning. Can you hear me?
Yes, ma'am.
Hey, so I was just wondering, with the CHG baths, when we document them on the work list, there isn't an actual spot to document. So in the ADLs, we just put like a comment. It says no other comment, and then I have them put CHG. But there is an actual add-on to the work list that's a CHG that we can do, and it's just an intervention where we click it and save it. But I did notice that the aides, because I don't know if it's just when the nurses add it, but when the aides go, they can't click it and document. Only the nurses can.
Okay. one step further from that as well. And Trisha and I are actually getting together after when she's free today. We are in the process of actually building a spot for you guys to be able to document the CHG bath. So that way we consistently have a comprehensive documentation location. So it actually has, critical questions about, how did the patient tolerate it? Was education performed? Was, there any skin breakdown issues noted? Things of that nature. So that will be an actual assessment that'll be made available. It is in the test phase right now. It has been built. So Trisha and I will be getting together sometime today in order to run through that and make sure it's built out the way that we're looking for. In the meantime, yes, you are correct, Becca. There is the orderable intervention or intervention for CHG bath. As far as it not being available for the text to document on, I did not know that. So I'm not sure if we're going to continue using that intervention once we get the assessment available and in place. But if we are planning to continue to use the intervention, then I will ensure that both the intervention and the assessment are available for nurses, PCTs, and CNAs for any member of the team to document, because as you're indicating, this is a task that anyone can complete on the team. It doesn't have to be just the nurse, right?
Hey,
All we're doing
Keenan,
is changing the type of soap that we're using. Yeah.
if you are making it an assessment though, then the text technically can't do an assessment. So you're
It's,
gonna run into an issue for that. Like if they're having to assess the skin and all of that, then they really can't document that.
I mean, I will kindly disagree, because it is an observation, right? And in the system, it is called an assessment, right? That's because that's all Meditech has. They have assessments and interventions, when in reality, it is just a type of documentation, right? So the interventions that are in there are like the one-click timestamp, put my name on here, I did this, but I'm not going to add any additional information to it, right? The assessments are the actual openable, hey, I can actually click boxes in here and type things, right? Same as we do for vital signs, same as we do for ADL stuff, right? So with that logic, right, the ADL documentation technically is an assessment as far as Meditech is concerned on how they design their product, but it's just semantics, right? An ADL documentation isn't an actual assessment like nursing assessment, right? Just like the CHG documentation isn't an actual assessment. It's just what Meditech calls them in the system. It's just a semantics thing. So I don't know what else they could rename that, and I don't know that we would want them to do that either, because then you're introducing another layer into the system and talking about a huge rebuild to rename things across the system. So realistically, no, it's not an actual assessment like nursing shift assessment or neuro assessment or ortho assessment or anything of that nature. It's just the way that Meditech names stuff in the system. Code blue buttons, rapid response buttons that are located in the patient rooms. These are placed in every single patient room for easy usage and easy spin up of hospital-wide rapid response and code blue situations. Obviously, code blue situations, this pretty typically is getting utilized. If we have a patient that loses a pulse, we're pretty consistently utilizing the code blue button. The opportunity that I see available for our team is those rapid response situations, right? It's when someone walks into a room for a patient that was different now than they were when you saw them that morning, and different not in a good way. And the person is then walking out of the room or using the radio to call to have somebody else come in, take a double look at the patient. Realistically, overuse of a rapid response would be a good problem to have. I can't say that I have ever run into any hospital or location that I've ever worked at where rapid response was considered overutilized. So anytime that we have situations where someone walks into a room and that patient is looking significantly different in a bad way than they did 5 minutes ago, an hour ago, 30 minutes ago, what have you, that rapid response is there in order to quickly spin up and get everybody to that room to start the assessment process. It gets you everybody that you need. And worst case scenario, everybody walks in and the person goes, "Oh, I just had to fart," right? And everybody leaves, right? So it is there to help quickly get you the staff that you need. There are multiple instances that I have heard from nursing staff, from CNA staff, from PCT staff about going into a room. Maybe it's in the middle of IDT, and so the floor is looking a little thin. They walk into the room, the patient's not looking good. They walk out of the room, they look to the right down the hallway, there's nobody standing there. They look to the left down the hallway, there's nobody standing there. They, boogie scoot down to the nurse's station real quick. The ward clerk's the only person that's there. Nobody else is in sight. You don't know where anybody is. The patient's turning blue. You're like, "Oh shit, what's going on? What do I do? Let me run down to the conference room really fast," right? And now we've kind of wasted 3, 4, 5 minutes trying to physically find help, right? That button is there exactly for those situations. That is what is intended for. That's what it's designed for, is to overhead broadcast very quickly, gets you some staff from the ED, gets you the hospitalist down there quickly, gets you your RT personnel. And with the overhead being fixed, we know that that's functional now. You're guaranteed that as soon as you hit that button, as long as we got somebody sitting at that ward clerk desk, right? And it does ring to the ED. It does ring over to surgery as well when you hit that code blue or staff assist button. So even if there isn't somebody sitting at the ward clerk desk, there's going to be somebody in ED or in surgery that's going to see that as well. And we can get that team spun up to get down there and assess the patient and start putting interventions in place to prevent something from going bad to worse. So anytime you are walking into that room and you're like, "Oh my God, what the hell's going on in here? I need to get some help." The first thing that you should do is, "I need help," is I need to push button on wall. That is where that should translate to. Those two things should be directly tied together in your brain. Because again, worst case scenario, everybody shows up and then they're not needed because the patient just had to fart, right? Or because they just were, laying on something sideways or whatever it may be. And that's not an issue. That's not an issue at all. People are going to return to their working areas. They came to you to help you and the patient, and if they're not needed, then they're going to return to where they, belong. So please, when these situations occur, don't go running down the hallways trying to find somebody. Use that staff assist button that's in the room. That's what it's there for, is to get you the help that you need there and quickly so that you don't have to leave the patient alone, right? You can stay there in the event you need to start compressions, in the event that you need to start suctioning, in the event that you need to start bagging, any of those items, you are there at the bedside, you're able to intervene, and you have staff coming to you. Questions on Code Blue, rapid response, and people responding? Mobility, daily care expectations. This is just a recap. This is one of those items that we kind of just consistently want to be shooting for on the target. One thing that I can say is my understanding is that we've been doing pretty solid on showers for patients. I'm not sure how we're doing on ambulation for patients. I do consistently see physical therapy and occupational therapy, getting patients up, moving them down the hallways. I understand that it is extremely busy right now and it can be challenging in order to get everything done to get to the point that you're freed up to be able to take a patient for a walk. But it means a lot for these patients, especially if you've got enough opportunity to take them on a decent walk and they're capable of doing that. You even have the permission to let them sit outside for a little while. If they're not on a telebox, it's an even more ideal situation. If they're on a telebox, ideally we should have somebody with that patient at all times. But if they're not, and they want to go outside, sit at the picnic table, what have you, that is 100% encouraged. Think of it as not just being a task to complete to get the patient up and move them. It's an opportunity for that person to go outside and touch some fake grass, right? Be able to breathe some fresh air that's not been circulated through the air conditioning system, you know, to be able to see the sunshine with their own two eyes and not through, you know, these shaded windows that we have in the patient rooms. I can tell you guys that after 2 days of staying in the hospital, I would be surprised if any person didn't start having a little bit of depression start to creep in, and just having that opportunity to pop their head outside for 10-15 minutes, get a little fresh air, go on a little walk, and be able to come back inside can be a total game changer for somebody. So it's just key. We want to make sure that we're on point with our real-time INO documentation, with our daily showers, with our daily ambulation for our patients. You know, that's what that 6-click is in place for, is to identify, do we have any assistive devices that we need to be using with this patient, and, you know, kind of get that concept in place that at least once we should be getting them up and moving them at a minimum once a day, for those patients that can get up and move. And for those that can't get out of bed, we want to get them up and sitting on the edge of the bed and doing something, whether that's brushing their own teeth, washing their own face, combing their own hair. And please, when you are, just like when you take a patient and you load them up in the shower and you give them everything that they need, and then they go off and they do their own thing, perfectly appropriate to do the same thing at the bedside as well. Set them up with what they need to wash their face or brush their teeth or wash their pits or whatever it is that they're going to be cleaning, and let them do that function. So that way they're doing as much of the work as they possibly can. And it gives them an opportunity to be sitting up out of the bed, doing something that's a little bit different. They're not just kind of stagnating like a potato all day long laying in that bed, getting skin breakdown over time. Wanted to touch on our end of shift expectations, and this is going to link into equipment as well. Key thing here, this is not a specific delineation between day shift, night shift, who's responsible for what. Every single person is responsible for ensuring that the trash is emptied before the end of their shift. Every single person is responsible for ensuring their rooms are clean, presentable, and patients are comfortable and in place, either up in a chair or laid down in the bed before the end of their shift. Every person is responsible for ensuring that their vital signs are their vital signs machines are being plugged in consistently so that they can maintain a charge throughout the shift. If we're noticing that there's a vital signs machine that really has a hard time staying charged, we need to be on top of it with getting our work orders in so we can get those batteries replaced, or we can get whatever is broken on that vital signs machine fixed. My understanding is we've had a vital signs machine that's kind of been Frankensteined parts from all the others to put one functional one together. That is not an environment that I want you guys to be operating in. I don't want you guys to have to be dealing with broken equipment. Our IT team will fix this stuff for us. We just have to make sure we get those work orders in. These guys are pretty damn good about, if we toss a work order in, they will be there to pick that device up either that morning or within 10-15 minutes of you dropping in that case, to be able to come over, collect that device, and then start working on ordering the parts so we can fix it up so it's functional for you guys. I want your equipment to be working. I don't want you guys to have to be dealing with broken shit. That's not an ideal situation, but we have to know that this stuff is broken. And that's where those work orders really come into play. As far as pulling something off of the floor and getting it fixed. So if you notice that, if there's a temperature probe that's not working right, or an SpO2 probe that's not working efficiently, or the blood pressure cuff seems to continue to leak, at the hose, get those work orders in. We'll get this stuff replaced so that it is functional for you guys. And please make sure that your daily duties, as far as towards the end of the shift, are handled and squared away. One of the worst things that anybody has to walk into is a room that's a right disaster, because no one took the opportunity to walk through and just basically do some simple, quick cleanup. And that includes physically taking out the trash after you throw it all away as well. Tossing it, cleaning up the room, getting the trash can filled up, getting the linen bin filled up, and then grabbing that stuff and taking it out of there. I understand this becomes challenging when we have a call off, or when there's only one aide on the floor and they're trying to hustle and take care of 13, 14 patients by themselves. Being able to get to all of those things starts to become less of a practical capability. This is where the nursing staff, it's a combination between both of you guys stepping up in order to help out that aide to be able to get those things accomplished so that the next shift is able to move forwards. Again, there's always that possibility that one or two things falls through the gaps, right? Maybe one room you weren't able to get to, but if you have 13 patients and 12 of the rooms you were able to get nice and squared away, cleaned up, trash out, linen taken out, patients are squared away, and there's only one left, where the person's room isn't cleaned up and you didn't save the worst one for last, kind of a situation, it's not as big of a deal. The next shift will be a lot more understanding and in line with being able to help out if you put that effort forward and get as much accomplished as you possibly can before the end of the shift. So that's where it becomes critical, right? I know that every person on this call kindly appreciates it when things are squared away. And they're a lot more likely to do that themselves if that's what was done prior to their shift as well for the next shift. So this is one of those kind of pay it forward items, and when it starts to fall through the cracks, it affects everybody. And more than anything, it negatively impacts the patients the most. Same thing. If I was up in a hospital for a handful of days, or any of you guys, and you had saline flushes and caps and baggies and 2 trays and a full linen cart with overflowing out the side, and poop still in your commode and trash overflowing over on the floor, you wouldn't be too happy about that situation. It's not ideal setup for a room. So just want to make sure we're doing our due diligence to get these things squared away for our patients, right? Any questions on end of shift duties, equipment? I know that we've got a couple of those vital signs machines are currently over in IT right now. Some parts have been ordered to get them fixed up. And I have submitted the request to see about getting those vital signs machines that we have, which are able to connect to the internet and Meditech, to get those set up and dialed in. So that way you guys can start sending vitals directly from the vital signs machine. Once we get that rolled out, there'll be some companion education for all of the staff, not only on how to use those vital signs machines and send, well, you know how to use the vital signs machine, but how to send the data. And then also some education on being mindful of what data you are sending when you are capturing vital signs and sending the data to the chart. So we'll do some education on that once that gets put together and we're able to roll that out. And hopefully that helps to save a little bit of time and make the vital signs process a little bit more efficient for our techs.
Hey, Keenan,
Yeah.
this shouldn't have to go, or this shouldn't have to go without saying, but lately it's been kind of an issue, and I've been kind of getting told multiple times, so I guess I'll just throw it out there that Cleaning up workspaces is an issue, has become an issue. So if you can just remind everyone to clean up their workspace, not to be, you know, keeping bags of, syringes and their needles and their extra things that they use for their shift. Once they're done with their stuff for their shift, they need to put it away. Take it away from the cows. Also, the vital signs machines have been like stuffed with extra things. If you use like the strips for the glucometers and all of that, you need to go return it back to the nurse's station so that we stop losing, the lancets and like all of these other things, and keeping trash, and use gloves inside of all the vital signs carts, and, all those things. It's just becoming sort of a problem. So,
If anybody is interested in an organizer to use on your WOW, like a little sorting organizer, I know that we've had different teammates. Some people may still already have, like on this call right now, might have one of those organizer bins. If somebody wants one, I will see if we can order those and you guys can have like a little organizer bin for your stuff. That way, I mean, they're probably maybe $5, right? Something cheap, got a little handle on it. You can throw your IV start stuff in there. You can throw some basics in there. And then that way, at the end of your shift, if if you want to throw that in your locker, or if you want to empty it out, or what have you, just something that's a little bit easier to kind of crate around your stuff that you need, but also potentially save some space on top of your well. I know I've seen a lot of folks use plastic bags to grab, IV start stuff and whatnot. But anybody that wants one of those little organizer bins, or if anybody has any idea for organizer bins for the vital signs cards, let me know. I will be more than happy to buy some Rubbermaid, little organizer things to help out with that stuff. So something we can get off of Amazon. So anybody that's interested, just reach out to me, and I can put an order in for some of those if we think that'll help. Trisha, I'm gonna put you on mute. So some other updates, communication scheduling, key thing here. We just want to make sure that anytime there is any schedule change that is done, or call off, especially, that the individual that is calling off, or the schedule modifications that are being made, we need to ensure that that communication is making it not just to the Google Sheets, but also over to the Red Book as well. So it is critical that anytime we have these conversations, and this is also helping me out to ensure that we're not missing this. Anytime we have any modification and schedule changes, please take that opportunity, shoot a message over to the charge nurse phone, or give a call over to the ward clerk desk, or if you're on that day, walk down, make sure you have that communication with charge so we can get it updated in the book. That way we're all on the same page as far as who's supposed to be where when, and we don't have instances where people aren't showing up when they need to be on site. There will be some changes coming up. We are being transitioned over to Paycom for our scheduling. I'm not sure at what point we're going to roll that out. I still have some digging and testing that I need to do in there to figure out how it's going to work. And then, of course, there will be education that'll come in line with that as well. I anticipate that once we move over to all scheduling being done through Paycom, that instead of having two different locations that we're keeping information, things will be a little bit more consistent as far as what the schedule is actually looking like coming out of Paycom versus going off of the Google spreadsheet that we have. So looking forward to what that has to offer for us. The phones have been updated. So I shared a MedSurg Teams post with everybody that has the manual included in there as far as the usage for the phones. And then I highlighted some of the key items like transferring calls, putting somebody on hold, doing the overhead, and doing the call to all of the phones. Key thing with the overhead is just going to hit everything on campus in the main building of the hospital. The overhead does not go to any of the outbuildings, but your call to all of the phones goes to every phone in the organization. It even will do the phones that are down in Quartzsite. So any phone that is connected to our network and tied in, if you broadcast over all of the phones, it will hit every phone that is hooked up to the system. So realistically, that could mean phones all the way out in Siloam, right, that are getting that conference call. So the function is still the same. There hasn't been any changes made to the emergency management process as far as which number we're dialing and the process involved with doing the overhead page. They have not made any modifications to the policy yet to also include doing the page to the phone system, or excuse me, doing the page to all of the phones. I'm not sure if they're going to make that change to ask that we do both, but for the time being, the policy is the same. Anytime we have any of those codes that need to be called overhead, they'll just be called overhead. You're not being told, and the policy hasn't changed to where you're doing both, calling overhead and calling to all the phones. If that does change, or if there's any modification to that emergency management process, I will update that with you guys when they make that modification. I'll also share that in the Teams post as well. And then of course they'll have to update the policy as well. So for the time being, any code goes on the overhead. But that all phones option is available. We just don't have any specific usage setting in place for that yet. In addition to that, we don't have to dial 9 for outside calls anymore. So that is one of the benefits of moving over to the new system. Please take a look at that post. It's got some information on how to do the transfers for the new phones. The transfer button looks a little bit different now. It doesn't say transfer, it doesn't say tran, it doesn't say anything like that. It's just 2 phone handsets, like what you pick up and hold to your ear, and one is pointing to the other one. That is the button for transfers. You'll find it on the phone underneath the button that looks like a mute button. So if you're trying to transfer a call, and then the process for transferring on those calls is the same as it was before. You pick up the phone, you're talking to the person on the other line, you figure out who you need to transfer them to as far as the extension, you hit the transfer button, dial the extension, and then wait for the other person to pick up on the other side. You confirm that somebody answered the phone, you give them a little precursor information about what this person that you have transferring to them, what they're calling for, just so that they're up to speed on what's coming their direction. And then you hit transfer again and it will complete that transfer. So you can actually perform a what's called a warm transfer without having to put the person on hold. This is the old system. Put the person on hold, call the other line, make sure they're there, and then bring the other person in and do the transfer. It's all seamless process now. So give that little guy a review, and then also I have that manual that's in there as well. It's very long. The manual is very long, but it is in a very well organized PDF format. It has a table of contents on the side, so you can quickly scroll through and find what it is that you're trying to do. Click on it and it'll take you to that page. So that way you're not having to scroll through the whole document to find what it is that you're trying to do. Questions on the phones? Anybody having issues with the new phones? ACOM, some changes have been put in place for PACOM. And the big change is that instead of the HR department having one person responsible for doing all of the modifications and handling whenever there are any punches that need to be adjusted, PTO hours that need to be adjusted, ESL hours that need to be adjusted. All of that is going to now route through each department's manager or director that they have in place. So what that means for you guys is that when you run into a pay issue on your time card or a punch issue on your time card, you'll be contacting me, and I actually have the ability to go in and modify those time cards now and put the correct information in on your behalf. So they have granted me the ability to do that. I do ask that please, 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 please make every effort to ensure that you are taking the steps to ensure that your time card is correct to begin with. So that means double checking to make sure that you don't have missed punches, double checking to make sure that you don't have a punch that needs a allocation adjustment, double checking to make sure that your PTO is entered correctly. For whatever reason, when people put PTO requests in on Paycom, it auto populates 8 hours in. I mean, I guess it kind of makes sense. So, you know, sometimes people will put in a PTO request that only says 8 hours and you're needing 12, right? So just double checking those things, it helps to speed that process up for me a little bit when I'm going through and doing payroll. I have already started going through time cards yesterday. And some of you, I've reached out to you to make those modifications. And then I'm also comparing against the schedule to make sure that, you know, there's not a complete missed punch or that you completely missed standby hours, right? But it really helps me out if you're able to ensure that you're monitoring that time card closely. And it helps me to make sure that I don't miss something as I'm going through. I'm not always necessarily going to be able to look at something and go, oh, well, this person was precepting with a nursing student on this day. And so I need to make sure I plug those hours in for them. I might not actually catch that. So it's just good standard. Every Friday, double check your time card. It only takes a couple of minutes. Make sure there's not any missed punches, and then make those modification requests. It makes it a lot more seamless, and it affirms that we're going to be getting you paid the correct amount come payroll day. So, and that I'm not going to miss anything. The only thing, so this includes education. So education hours, instead of sending that request over to HR, I'm going to ask that you guys send those requests to me via email, date, time, how many hours of education, what were you doing for those education hours, so that I can get those hours added in for you. Same goes for callback pay, not that we run into a lot of callback pay in our department. The only one that is still has to run through HR for approval is when we have pool shift pay being assigned for a person's time card. So that's the only instance in which I have to run that through the HR team, and it actually comes from me as far as getting pool pay adjustment for somebody's time card. Questions on Paycom updates, Paycom changes? You guys aren't going to see anything different on your stuff. It's not going to look any different for you. It's just instead of reaching out to HR when you have a problem, you're going to reach out to me. And then I can make those edits. And then same thing, I'll be reaching out to you guys as well. So when I'm going through those time cards, if I see something that doesn't make sense, or if there's a punch that's missing, you know, I'll connect with you to confirm, you know, what it is that we need to get plugged in there as we're getting close to payroll Monday.
Yeah, Keenan, are we still doing punch requests for like meetings, especially when we're off-site? That's how I've been
Yes,
doing it.
please. Yes,
Okay.
please. Yeah,
Okay.
same thing goes. And anybody that is doing anything work related, whether that is a meeting that you are attending virtually, or I have you working on a project from home, or whatever you're doing, health stream from home, you're doing, you know, I have you making Christmas cards for everyone on the team, or whatever it may be. If it is work related and it is something that you are doing and you are not on site, those would be hours that you can punch for whatever it is that you're working on. If you're doing chart reviews, if you're whatever it may be, please make sure that you're keeping track of that time. If I call you on the phone and we have an hour-long conversation, right, about work-related stuff, please punch your time. That's technically a meeting, right? That's a one-on-one meeting that I'm having with you. So please take those opportunities. I want you guys to ensure that you're being compensated when it comes to work-related items. So, but I do need you guys to put that time in. I'm not gonna, hang up the phone with you after an hour later and then go, oh, I need to jump in and add some hours for that person. I do need you to take the reins on getting that time plugged in when those things happen. And then just kind of a couple of last minute items, and then we'll open up for roundtable. We already talked about the upcoming edition for the CHG documentation for everybody in Meditech. Tricia and I'll be getting together later today to do the testing on that. We have the leave of absence workflow that is also in testing phase as well. We're very close on being able to roll that out. We're just making sure that the settings, because we have to preset the settings, we're running through that now to make sure that our presets are solid and in place. And then we're confirming that this leave of absence process will be able to meet our needs as far as when we send patients to infusion, CT, MRI, if they're going for a surgical case, if we need to flip them over to OBS for 2 days to work them up for chest pain, any of those items we'll be able to have this leave of absence registration thing in place, which at the end of this, once we get this up and moving, it has the potential to save us about 50% of the documentation that we're currently having to do when we're flipping these patients' accounts around. So that is what this is going in place for, is to assist with when we're doing that swing to inpatient, back to swing again, and or swing over to infusion and then back and then over to surgery, just to help save time, make that process a little bit more effective and efficient for you guys. And reduce the overall amount of documentation that you're having to do. And it's not just you, it impacts the docs, it impacts the rehab crew, anyone that is doing any documentation on that patient's chart. It'll help to save a lot of time because your documentation and everything will still be there once we return that patient from that leave of absence status. So some work in progress on the testing side of that. And once we get it all dialed in, there'll be formal education that comes out as far as how it's going to impact that account, and then also what the workflow is going to be step by step when we need to do this leave of absence for a patient. And then I did want to ensure that we took an opportunity to welcome. We have a handful of new CNAs and PCTs that have joined our team. We've added some new graduate nurses. We've had some recent new hires that have added on. I want to make sure that we're giving all of these individuals an opportunity to feel very welcome. I understand that this is a very busy part of the year, and it can be difficult to have that free time to connect with the new folks as they're joining the team, but we want to be as welcoming as possible. We want them to understand the kind of family environment and culture that we have on our team as well as in the organization. So please, when you come across a new person, take an opportunity, have a quick conversation with them, find out something new about them that you didn't know before. Maybe sit down and have lunch with this person or invite them to lunch with you. Include them when, if you guys are making coffee. I know Cindy likes to make coffee for folks. If you guys are doing one of your potlucks that you do on night shift, get these guys involved. Get them on board with bringing them into the culture of the team so that they feel nice and welcome joining us. And then I wanted to do some shout out. I'm a little proud of this one. We had 12 DAISY nominees out of a total of 20 DAISY nominations for the year of 2025. So our department exceeded over 50% of the Daisy nominations came from our department in 2025. So please take an opportunity to pat yourselves on the back for stepping up consistently across the board. This is patient recognition. This is coming from your patients, putting in these nominations on your behalf for the nursing team. So please, I want to give that recognition to everybody. And then would also like to highlight that the Daisy winner for 2025 for the hospital was our own Tammy Knight, and she was celebrated at the Christmas party on the 7th of this month. So please, if you didn't already know that, Tammy did win the Daisy Award for the year of 2025. Take an opportunity, please congratulate her on making that happen. We all know Tammy. We work very closely with her. We know how passionately she cares for her patients, and just want to highlight, this is that recognition that really shines from the patients for our team members, and I couldn't be more proud to see that over half of those nominations came from our department. So please keep up the good work, guys. The patients are appreciating you for what you do. So the work that we're doing here clearly shows. So despite any of the qualms that we may have, or issues that we run into, or process breakdowns, or frustrations that we have on our shifts, over half of the Daisy nominations for 2025 were our team. So we are doing something right. So despite whatever negative directions that we may lean in, or thoughts or ideas that we may have, or frustrations, just know that we are doing things right for our patients. We're getting that recognition that we all deserve for the work that we do, which is why we're here in the first place, right? Is for the recognition. That's why we do it. We do it for the patients, right? We do it to take good care of them, to be able to use our compassion that we have for other people, and to do right by them. So please keep it up. You guys are doing an excellent job, and congratulations to Tammy for her winning the Daisy nomination of 2025. I also want to highlight as well, we have a handful of team members that have made it through some of their semesters for nursing school. We have a handful of team members that have recently entered into CNA school. As you guys know, we do try to position ourselves as a teaching hospital, and to take these opportunities to really grow our own internally within the organization. And that's kind of the big effort. We're a small community. It's hard to get experienced people to want to move out here and work out here out in BFE nowhere, Arizona, right? And so we really have to put those efforts into growing our own. And so anytime we have staff that are on our team that decide to go the distance to get enrolled and do their CNA, or to get enrolled and make the progress through nursing school, nothing but proud of all of our teammates that are stepping up and making that happen with their education. And please, anyone that is interested in going the distance and continuing their education, please, our education department is there. They're available for you guys to ask questions about programs, whether that's CNA programs, nursing programs, master's programs, you name it. They're there to help you guys out with the research on this. And please know that as a rural facility, we do have the ability to apply for the federally funded scholarship or loan repayment programs that are available through the Fed. So if financial reasons is one of the things that's holding you back from being able to go the distance and go through nursing school or RT school or X-ray school, please keep in mind that there are financial resources out there to help mitigate the financial burden of these programs. If you're interested in finding out more information about those programs and what's available, please reach out to me, reach out to the education team. We're more than happy to share that content with you. I'm not going to put your application in for it, but I will show you where to go and what to look for in order to be able to apply for those programs. With that, I will open it up. Anybody that has any questions on the team, please feel free to raise your hand, pitch in, whatever you may have. We're here to chat. All right. If nobody has anything, then we will convene. I do have the recording on this meeting, so I will be uploading that today so that those that weren't able to attend in person are able to watch back the content that we were able to cover and share today. You guys enjoy your weekend and early Merry Christmas. If I do not see you before then, I will be here Monday, Tuesday, and Wednesday of next week. And then I'll also be here on Friday. So the only day I won't be here next week is just Christmas Day. So please reach out, connect, and Merry Christmas. You guys take care.